and then soon so them say boy and rano say and then ye beka ye ni eho asem doctor ba ko so asiesie ne ho wodi ene ani ho asem enso no wodi ebebre na ansa na kra no bi me fa kwanya yi so na me kase nipa dodoa yetimi efra manfo enka won omunya kwanhwefo etimba lai so no mestre say but some what me nka de
you
me das because me video no emma no ya na me too sure yeah that's opinion enti dodoa na yetimi edi efra hofro eba lai so emu beti adwumadi mesre se obi bia utimi de adofo aso adofo bi ba lai so no mesre se odi ni pakro din en number bema da sesu any personal ministry leader se be ya betimi afollow in pakro no na ye wo akyade soronko so a epese de ma on omunya konhwefo a omotimi abeka ye ho no yo apomodin krata hodo pi epese ye de ma adofo eti mesre se yen etimi efra ho from mbala isu no yen frɛ eda sesu wuni number ofrɛ ne ho kania no sabeka no aso ka se ofrɛ secretary se opɛ eda sesu number no sabeka na watimi edi ni pakrodin ama eda sesu ne yeso timi attract ni pakro no na akyɛde a ɛyɛ apomodin krata no etimi edi ama saa enipa no na me koswa kai say yeni ya your conference line so no so conference line so a wutimi emusa question it say wasem bisa ahodo a better say we ba zoom so so the be ya the better train ewie a ubotimi na kwan na obusa wasem bisa enti yensa no so ene yensa ebre no mesre ama opanyini Alex Ajimai abo ye opening him no amaye na obowia na eda back gel nso no abompaye amaye ti ebo ye hopi epin him no
yam bofo ne agifo ayi na asie ntontom ne munyam ka udin Yehowa yɛda wase wadom no wɔ homɔbro de adom yɛn yɛda wase na da yɛdi fire ne afiba mu bɔ yɛn ho ban de yɛkɔba asomdwie mu ayi yɛn ka udin yɛda wase adesua soronko a wode nam wɔn koa so ahyehyɛ de ama yɛn yɛda wase soronko kwan so ɛnora wonam wafra frimpɔn so duafo frimpɔn so na afei nsɛm a wode maa yɛn ayi yɛn ka udin soronko kwan so anwumre no yɛde duafo Thompson hyɛ wɔn nsa so sɛ siesie no afei fa nsɛm fa mu nsɛm ɛbɛboa na afei siesie na yie nsɛm ɛbɛma apɔmuden na afei yɛtumi nya nkwa ho san na afei yɛde asom wɔ ɛne yɛne ɛwɔ la yesu nyinaa de ho hyɛ wɔn nsa siesie adwene ne akoma na nsɛm ɛbɛn no yɛntie na afei ntumi mmoa yɛn na afei ɛma ahoɔden yɛtumi de asom yie yɛde wase yɛnamfonom ne afipamfoɔ a yɛto wɔn nsa frɔ no nyinaa waba a wɔbɛtie wɔn nsɛm ne wɔn a wɔyɛ nhyɛ na afei wɔn nyinaa ba bɛtie wɔn nsɛm yɛnu sɛ wodom no adesua bɛkɔ awie no na wafa so de ahyira yɛn na afei wɔsiesie ayɛyie na aseɛ ntontom nka wo din sɛ wɔkasa afɔ duafo Thompson mu wɔ adom ti amen
amen ɛda wase pii nyamema ɛde nyankopɔn wase baabi a ɔde yɛ abɛduru eyi na sɛ no mekaeɛ no sɛ ɛnɛ atoyɛ nsa afrɛ Dr. Panyini baako a ɛnɛ wɔde yadesua no wɔde ɛbrɛ na ɛnɛ ɛyade a yɛbɛkasa afa ani sɛdeɛ yɛbɛhwɛ yɛni yie ɛne aniyareɛ ɛne de wi ani no koraa no ɔsɛ yɛfa ɛbɔ ho ban ɛnɛ ho adesua ɛna Dr. Panyini ɛde ɛbrɛ na yɛmɛ no gye paa sɛ yɛtu yɛn nsa ɛfrɛ doctor yi na ɔkɔgye pene sɛ ɔreba na nnɛ ɔbɛboa yɛ sɛ wɔyɛ very busy paa ɛnɛ kora na dwumadie pii da n'anim nanso ɛnam first Ghana ho do ne nti no ɔgyae dwumadie de nyinaa ato hɔ sɛ ɛnɛ ɔbɛboa yɛ ama yɛn nso no yɛnya apɔmuden ɛwɔ yɛni ɛho na doctor yi a meka ne ho asɛm yi na ɔyɛ first Ghana asafoba mmerɛ bi a atwam between 1988 to 1997 yɛne yɛwɔ asɔɔdan mu hɔ no deɛ megye sɛ ebi a yɛne a yɛwɔ first Ghana saa berɛ no deɛ na megye sɛ yɛni no na saa time no na ɔyɛ abɔfra ketewa ɛwɔ asɔɔdan mu hɔ nom nti ebi a sɛ deɛ ɔnyɛ duru no ebi mu bi ɛnhyɛ ne nso but na ɔwɔ yɛn asɔɔdan mu hɔ nom ebi between 1988 to 1997 na ɔ first Ghana SDA church na ɔmaame yɛfrɛ ɔmaame Naomi ɛna ɔpa nso de Mr. Ben na Ben saa time no deɛ ne ɛwɔ asɔɔdan mu saa time no deɛ yiri sɛ ebi a yɛbɛkae doctor yi ate ɛto ne nsa afrɛ enu ansa na ɔmo free first Ghana 1997 na ɔyɛ obi a abɔ nwoma paa na ɛka sɛ medicine deɛ a ɔyɛ ade a wabɛn mu yie ɛnka ani yareɛ ho yɛ ade a wabɛn mu yie na ɔmo sua hunu paa ɔhyɛ ne school ase ansa onya no degree first degree ɛwɔ Harvard University ansa na ɔtoa so akɔ Case Western Reserve University na ɔkɔyɛ ne medical degree ɔhɔnom owie medical degree no wamena so hɔ a ɔyɛ n'adwene sɛ ɔpɛ sɛ ɔboa ɛyarefoɔ ɛnka ɔmo ani ɛho nti ɔyɛ n'adwene sɛ ɔbɛ specialize ɛwɔ ani yareɛ ɛnso ɛho nti ɔtoa so ɛkɔ school ɛkɔsua ani ɛne yarewa a ɛha ani ɛho saa bere a me ne mo kasa yi kakraa bi na wɔwie another sub speciality ɛwɔ ani no ho a ɛsɛ ɔsua the way a esi bi yɛ ani no ɛfa baabi a ɛfrɛ no retina the way esi bi yɛ ɛhɔnom surgery a sama ya obewie na ɔkɔ toa so aso akɔyɛ n'adwuma me no kasa ɛnɛ saa bere ɔne yɛ kasa efiri ayewa no ho a wasɛ ne bra ɔde bet church yɛ saa abere na ema nika pa say ni busy time nyina no wagya ato ho na obekyerɛkyerɛ enne danwin na oyobi a oye warefo a ne hokani ene efia kyerɛwa aba minim se no so first Ghana dia ende wa anka nkyerɛ no it Dr. Thompson say owo afidie so a nanka mesre nanka oso wai nanka first Ghana yenso yehu anim ene ye mo akwa aba in fact what me too ho.
Hello. Design.
Yeah, boko. I did go Dr. Thompson and who know your video. Yamo Akaba Press Ghana.
That's CP, thank you.
Almost on my show. Be say from that time, no my first Ghana view.
This is my film.
Oh, okay. First Ghana sometimes Ghana matter that was it. Say what in your bala is. Now be boy, then nimdia wanya ewa ni yare ho no. We boy be kyerɛ yɛn so. Na ansa na mbeje mu ama Dr. Thompson de ne dwumadie no aba no. Mesre ema Eda Alex Ajimai. Abo a team song na maye na ewi a nipa yɛbɛtene nka no Dr. Thompson. Nyame nhyira yɛ wɔ na adom nti. Amen.
Amen.
You doing your best to turn from sin. You think you're the worst, but don't give up. You never alone. You know your own. You'll be faithful to complete it in you. You doing your best to turn from sin. You think you're the worst, but don't give up. You never alone. You know your own. You'll be faithful to complete it in you.
He who started the good works will surely bring it to completion. Give it all your best and leave him the rest. He will do. Don't forget to read his word and lead him daily on to prayer. Trusting every day on his promises, he will do.
You've fallen again, you've gone astray, but Jesus will reign if you give him your way. He's calling to you to take you through. He'll be faithful to complete it in you. You've fallen again, you've gone astray, but Jesus will reign if you give him your way. He's calling to you to take you through. He'll be faithful to complete it in you.
The Bible tells us in the book of Philippians chapter 1 that he who started the good works will surely bring it to completion. So no matter what you're going through, be rest assured that your victory is secured. Why not sing hallelujah, praises to the Most High God who reigns on high, for he's worthy, yes, he's worthy of our praises. Hallelujah to his holy name. We adore you, Lord. We praise you. We lift you, Lord, and we magnify you. We adore you, Lord. We praise you forevermore. You are King of Kings, the Lord of Lords, Holy One. praise, Almighty God, the great I am, we lift you high. Oh yeah, Nyanko Jesus, oh yeah, Himoji, Yesu, oh na uni, say, Danina, oh yeah, Nyanko Jesus, oh yeah, Himoji, Yesu, oh na uni, say, Danina. Abba Father, we want to say thank you for your love, thank you for your grace. We adore you, Lord, all the things you done. Father, you are loving, gracious, merciful. Hey, Jehovah Jireh, we worship you. Jehovah Nissi, we bow before your throne. Adonai, worthy of the praise, we lift your name on high. Ooh. Oshe Baba, Olua, Eradi, Bejiwa Yeye, Bejiwa Masi, Eremera, Elohim, Adonai, Shaddai, Okokoko, Bejiwa Yeye, Onase, Ontonto, Jehovah Nissi, Jehovah Jireh, Elohim, Mawasu, Yewagesim, Bodi, faithful Father, thank you, Jesus. Our James, Yakutu, Yasari, running sour, running sour, running sour. Opiaraniwa, He will be faithful, he will be faithful, he will be faithful. He will be faithful to complete in you.
The Yankopon say, and Pat Yankopon be faithful to the end. And here, Dr. Thompson, the Saturday, Mjuma, and the Shia Honor, what's me Eddie Abre. Yamin Kaho, one shouting, now a morning, dear. The church say, and yes, a timid Diduma, now boy, and made me a translate our Pumdim. I mean, sit out, or now doom. Amen.
Amen. Amen. Dalcy P, thank you, Penny, for that lovely introduction. Good evening to everyone. So I am Ian. I'm sure a lot of you are familiar with me and Penny Kayan. I actually grew up in that church, and see much of my understanding about Christianity and the Adventism in every pews. And it's amazing to see what First Ghana has become. And Debia, when I turn in, it's wonderful that the congregation stays so engaged. And I hope that the Lord will continue to bless you and the congregation, the elders and the pastors, as you serve faithfully. And I wanted to thank the congregation also for giving me this opportunity to speak with you and for setting aside some time to address some of these important issues. And in that, my presentation mostly about in English. Now, so more questions between me and English, and I say tree fante
Good.
So the goal today is a bird's eye view of the most commonly encountered vision-threatening diseases in the Ghanaian population. So again, the goal is to cover the most commonly encountered blinding diseases in the Ghanaian population. So this is not about the American population and not the world population, but this is actually the kind of diseases that affect us. And the aim for this presentation is knowledge transfer. And see, if you don't learn anything today, it means that I have not done my job. And I don't want there to be any surprises. I'll only look at 3 topics. Those 3 topics, we can talk about them for many hours, but for the sake of time and my own voice, we'll make it short and try to keep it under 40 minutes. And so for everyone who's listening, if you live long enough, I guarantee you that of those 3 diseases, if you live long enough, you would get one of them. If the Lord blesses you and you are able to avoid even them, then someone in your family or your friends will definitely be affected by them. So if you don't take it for yourself, that's fine, and at least take it for someone else. Before we start, just to kind of take a step back and take a scriptural view, it's important to recognize that all affliction, all sickness is from Satan. You have 2 eyes, and Satan would love to corrupt your vision. He would love to take away one of those eyes or both. And why would he like to do this? Well, the Bible says, let your light so shine before men, that they may see your good works and do what? Glorify your Father, which is in heaven. So the key phrase there is that they may see. The enemy would love to blind you. Spiritually, absolutely. Physically, indeed. God has given us 5 ways of experiencing this world: our touch, our taste, our hearing, our smell, our sight. But Satan would love to put an obstacle in those paths, block those pathways, to deprive you of your joy, to affect your ability to care for your family and provide, and to bring you into despair. So I encourage you to use this opportunity to fortify yourself to guard against these attacks, to improve your general understanding of the eye, and that's matters of health as it pertains to your vision, to keep what God gave you as best you know how. And let me pull up the screen. I will be sharing some slides. We will be looking at some pretty accurate pictures of the eye and surgery. So anyone who's squeamish, I'm alerting you now. You can feel free to avert your eyes. So the title of this presentation is The More You Know, The More You See. Again, the more you know, the more you see. And the question is, who am I to be talking to you about the eyes? It's a good question.
Recording has started.
You asked that. So my main job is I'm what you call a vitreoretinal surgeon, which basically means I went to med school. I specialized in the medical and surgical care of the eye. Then I did some additional subspecialty training to develop expertise in doing surgery at the delicate structures in the back of the eye. So in short, I cut open eyeballs and I put them back together again. Now I bring this up to say that I'm part of a team of health professionals who take care of the eye. So if you've ever had an eye exam, or you needed glasses, or you had problems with your vision, you probably interacted with some member of that team. It's unlikely that you've interacted with me or a retinal surgeon, because usually by the time you see us, it means things have gone really wrong and you need surgical intervention. But it's important to know who you're interacting with and what roles they play, so that you know where to direct your questions, and so that you don't waste your own time and that you don't waste the provider's time. So when you go see, let me go ahead and bring this up all the way. All right, here we go. Can you guys see the slides?
Annie.
Yes.
Okay, okay, done. Excellent. All right. So typically when you interact with an eye doctor, you're interacting with 3 potential individuals, right? There's an optician. That's someone who basically helps make glasses and helps fit you for glasses. They can't write prescriptions. They don't actually measure the strength of your glasses, but they will help you find a good fit for your face. And you know, to be an optician, you do a certification. They're very helpful in that role. You could also potentially see an optometrist. There are more optometrists in America than there are ophthalmologists. And you know, what is an optometrist? Well, an optometrist is someone who's gone to college and someone who has decided to specialize in the eye and has gone straight to what we call optometry school. And so they are what they call a doctor of optometry. So that means they can see you for yearly checkups. They do it, examine and diagnose certain eye conditions. And they definitely treat what we call refractive error. So if you need glasses, someone who's good to see is an optometrist. They have an expertise in kind of figuring out if you're nearsighted, farsighted, what kind of curvature affects your cornea to help you maximize sort of your vision. They can also do contact lenses, and they have a few specialties with regards to people who have really low vision. Now, if you need a higher level of care, the optometrist may refer you to an ophthalmologist for more specialized care, or potentially if you need surgery for surgery. So what is an ophthalmologist? So an ophthalmologist is someone who has gone to college, med school, and then they decided to do 4 years of training precisely in the eye. And so they basically can diagnose and treat all eye diseases across the spectrum, from glasses all the way to surgery. They tend to perform more complicated procedures. They tend to also be involved in scientific research to look for causes and cures of eye diseases and vision disorders. And because they are medical doctors or physicians, you know, they'll often interact with the rest of the healthcare team to take care of issues that affect the body, but also can affect the eye. Sometimes an ophthalmologist may need to refer you to a specialist. So someone whose focus is in very complex diseases of vision. So within the eye itself, that small organ, there's another 7 subspecialties. I won't go through and talk about all of them, but I only bring this up to say, I think someone raised their hand. I'll tell you what, we'll reach a point in a few minutes and I'll take your question, okay, Galaxy? So the reason why these subspecialties exist is that some of these structures are so delicate and they're irreplaceable. You don't get 2 of these, that you want someone who only deals with this subject over and over and over again. That way they develop an expertise, they develop a comfort level, and they are capable of taking you through this kind of surgery or intervention that you need. So the purpose of emphasizing this to say, whenever you get referred up, you don't want to make sure that you reject that referral. You continue to go see that specialist because it means you have a condition which really can't be addressed by your general provider. Okay, so we are going to jump into a little bit of eye anatomy, but before, I'm going to see Galaxy Note has a question. So is it okay if I take his question real briefly? Okay, no problem. Okay, and Galaxy, well, at the end, we'll reach your question, okay? All right, so let's look briefly at this eye. So, so this is just a general picture of the eye, and it's as if you've cut the eye in half, all right? And just looking from front to back, the important thing to recognize is the front is here, right? So light enters the eye, it goes through the cornea, and the cornea is the area where you may do LASIK surgery or refractive surgery to correct vision. It passes through the pupil, through the lens, it gets bent to focus on the retina. The retina sends that light stimulus message to the optic nerve. The optic nerve carries it to the brain. Your brain sees it, and your brain interprets it. So the reason I bring this up is to say that vision occurs in 2 places, right? It occurs in the eyeball, but it also occurs in the brain, right? Without an eye, you certainly won't see. But actually, if you lose a certain component or a certain part of the brain, the visual cortex that's responsible for interpreting vision, then you will also be blind, even though your eye works perfectly. And so the reason I bring this up is to say some visual disorders have nothing to do whatsoever with the eyeball. They are located back in the eye-brain connection, or they're located in the brain itself. And so that's why it is important not to self-diagnose, but to see a provider, because there really is a long range of potential areas where your vision could be affected that is not just in the eyeball. So the first thing we're going to talk about is cataracts. Now, cataracts is something that if you go to Ghana, there are about 31 million people, maybe 32 now in Ghana. And when it comes to blindness, meaning vision that's really bad in one or both eyes, the number one cause of blindness in Ghana is cataracts, which so 54% of people who are blind, they are blind because they have a cataract. Now, I'm sure most of you have heard this term cataract. We have this concept of something in the eye that goes wrong. So the cataract is a change that occurs in the crystalline lens in the eye. So as we discussed, this lens sits dead in the middle of the eye. And when you're born with it, it's in its purest, cleanest, clearest, colorless state. And it's almost like silicone. It's flexible. It can bend to help you see things up close. It can relax to help you see things far away. So it's really at its optimum when you're born. Over time, though, this lens changes the same way that people have gray hair, like my beard, the same way people develop skin that sags and changes in the texture of their skin and hair. The same way you have age-related changes that occur in that lens. So over time, those changes make that lens more rigid. It becomes firm. It loses its ability to be elastic. Some of you have noticed that in your 20s, you could see up close really well. But then some point in your 40s and 50s, you no longer can see up close. And that's because that lens that used to be able to bend so easily now is rigid and hard and can no longer accommodate you to see up close. We call this presbyopia. And that's usually where your doctor will prescribe for you bifocals or give you some glasses to help you see up close. The other age-related change that happens is it's not just the elasticity, but it's also the color of the lens. The lens is designed to be clear, to let light through. But with enough exposure to just light, aids, and especially ultraviolet rays, the lens changes from being clear, like you saw before, to now being opaque and translucent. It can take on different colors. It can be brown, it can be red, it can be rusty. It's a change in the molecular structure of that lens so that it no longer lets light through. So if you think about it, if the lens does not allow light to pass through, then the retina that sits at the back that's responsible for getting that light can no longer receive that signal. The signal becomes weak. And as a consequence, what that means is the way you see changes. Now, there are different types of cataracts. Here's just an example. You can have cataracts in the front of the lens, in the middle of the lens. You can have it on the sides of the lens. You can even have it on the back surface of the lens. All these will change the way you see a bit differently, but they still degrade the quality of your vision and the precision with which you're able to see. And that's just an example up close of a lens where a lot of the change and the opacities are in the back part of that lens. These are changes that we sometimes see with trauma or we can see in diabetes. So when people have cataracts, other than degrading the vision, how does it change the way you see? Well, on your left-hand side, you can see this, what we call halos or scattering. Or sometimes we call it starburst. So particularly at night, when you're driving or when it's very dark, because when the light hits your lens, those areas that are harder and more opaque, they scatter the light so that instead of seeing a pinpoint area of light, you see this blurred image with streaks going in every which direction. Particularly when you're driving or when it's raining, this can be so debilitating that people will even stop driving at night particularly because of this issue. And this is something that potentially could be fixed if you bring it to the attention of your eye care provider. And it's not just the bright lights that also become foggy and blurred, but actually all colors kind of take on this dull hue, and bright lights become brighter, dark lights become darker, and it really can mess with your ability to discriminate and see, particularly in the dark. Now, there's a saying here that love covers a multitude of sins. And the same way, sunlight also covers most of these errors. So a lot of times you'll notice that the vision is so much worse in the dark than it is during the day. And that's not a signal to you that you're doing okay. That's actually, as soon as that vision starts to get bad in the dark, that's a signal to you that you may have this cataract creeping up, and we may need to look at it. So how does a doctor examine this lens and diagnose you with a cataract and determine if you're ready for that cataract to come out? Well, the way that happens is that we essentially use a microscope, or we use a slit lamp, and that allows us to look deep into the structures of the eye and magnify them to get this high definition view. So it allows us to see what particular part of a lens is changing. So the question everyone asks is, well, okay, you said I have cataract, but can I just get another set of glasses? Can I just change and go for my spares? And yeah, in the early stages, absolutely, you can get different glasses. It can potentially help with some of that blur. But as that cataract progresses, the glasses will no longer be able to help. And the only way to bring back that surgical clarity is to undergo surgical removal. Now, this procedure happens in an operating room. And I do want to cover it briefly because there's a lot of fear, especially in conditions like this where you go under the knife. So most of the time it's done, you're not put to sleep, right? It's a 20 to 30 minute procedure. We make you comfortable. We may sedate you a little bit so that you're not too anxious. It is the most commonly performed surgical procedure in the world. I mean, it's been done so many times that it's now down to a precise science. People who are really good can knock this out in 7 minutes. I mean, you can be on the table and 7 minutes later, your cataract is out, the new lens is in, and you're on your way. Usually you need a day of recovery, okay? They might put a patch over your eye, but the next day, a lot of people are seeing just fine. It usually takes a week to a month before you reach your optimum vision, but you can go back to work as soon as 2 or 3 days later. It all kind of just depends on the surgery. So what is the surgery? So basically, we make a small incision in the front part of the eye. We put little tiny instruments into the eye, and then we break up that lens using bursts of ultrasound energy. And it basically smashes the lens in a controlled manner and liquefies it. Then we take another instrument and we vacuum those lens contents out of the eye. Once we've removed the lens, we take a small, clear plastic lens like this. So that's someone's finger. It's tiny. And we slip that in back in the eye in the same place where the old lens used to be. Now, it's important to know, it's improved your vision, but it's not like you're going to get back to the vision you had when you were 18 years old, right? There's a whole eyeball involved, and we've just changed the lens. But it can definitely be life-altering for many people, particularly if you've never had the benefit of glasses and if you have a really bad cataract. Usually, too, you have to make some decisions. So the lens corrects for a particular distance. Either you correct for seeing far in the distance, or you correct for seeing up close. And if you correct for seeing up close, you may need to wear glasses to see in the distance. If you correct for seeing the distance, you may need glasses to see up close. Now we have some new lenses, and Medicare will cover this, but now we have some new lenses which Medicare will not cover. Those cost anywhere from $1,000 to $2,000 out of pocket. And those actually will correct for far away, intermediate, and sometimes even up close. They're not for everyone, because one, they are pricey, and two, not everyone can deal with the changes in the refractive power that it induces. But for those where it works, it works in a spectacular fashion. And this is just an example. Most of the time when we're doing the surgery, we're not using heads-up platforms, meaning our eyes are looking into a microscope. But more and more now we're employing technology where you can do the surgery at the patient's head, but you can be looking in the distance on a huge monitor that's basically showing you your movements in a high definition magnified view. So I bring this up to say that it's really a procedure where it's been studied, it's been examined, we have improved it. It used to take an hour and a half. Now it can take anything as short as even 7 minutes. It's something, if you were going to do any surgery at all in this life, this is absolutely the one surgery you should consider if you need it. So I guess the question would be, well, I prefer not to have a cataract. Unfortunately, it's going to come, right? The only thing you can do is potentially delay the onset. And how you delay the onset, if you smoke, quit. Smoking is terrible. You don't need me to tell you to quit. Try to eat green leafy vegetables. It provides antioxidants that prevent some of the reactions that can occur to change the nature of the lens. Keep your eyes covered to protect them from trauma, and wear sunglasses. I know that traditionally we come from a sunny place. And so sunglasses are not something we typically put on. But beyond the comfort and the style, it actually can help slow down the rate of cataract progression. So it is something to consider. Okay, so we're going to move right into glaucoma because I think that's also another key issue that people of African descent have to wrestle with. So when I told you that if you look at blindness, particularly in Ghana, and this came from a 2015 surveillance study done by the Ghanaian government, 54% of blindness comes from cataract. A good 20%, meaning 1 in every 5 people who is blind from glaucoma. And they call this the silent thief. The reason they call this the silent thief is that, unfortunately, most people who have glaucoma won't be able to identify it until it's too late. So let's talk a little bit about glaucoma. What is this disease and why does it seem to affect people of color more so than it affects others? So glaucoma is a condition where the connection between the brain and the eye becomes increasingly diseased. And it progresses until that connection just stops working altogether. Now that connection between the brain and the eye is this long, curvilinear thing here. We call it the optic nerve. It's kind of like if you have a satellite and it's connected with a cord to a TV. The satellite is the eye, it receives the information, then it sends it along a track to the TV or the brain where it's interpreted and comes out as an image. But this cord, this optic nerve is not just one connection. It's actually 1.2 million tiny fibers or neuronal axons that leave the eye and go and connect the structures in the brain. So when glaucoma occurs, slowly you start to lose those fibers. So instead of having 1.2 million, you may have 900,000. It can get to a point where you're left with something like 200,000 or even 100,000, and then that connection becomes really weak and attenuated. And that's when you start to lose your central vision. So if you're looking at it in terms of the world, there are over 3 million people in the USA. And the USA is about, I think, 300 and something, 30 million people. About 3 million people have glaucoma, and half of them don't know it. And about 120,000 people, unfortunately, their condition progressed to the point where they are blind. Now I mentioned, this is the study that I was looking at, the Ghana Blindness and Visual Impairment Study done in 2015, which showed again that glaucoma represents a good 1 in 5 or 20% of everyone who is blind, at least in Ghana. Some of the risk factors for developing this disease are African ancestry, that's us, age, and family history. And we think that approximately 8.5% of people over the age of 40 who are Ghanaian have glaucoma. So that means if you think about our church with 200 people, at least 17 of them, in a conservative estimate, have glaucoma, and maybe 8 of them don't know it. So let's talk a little bit about what glaucoma is and what we do to sort of manage it, to give you some more information. So the eye has its own pressure. It has an internal pressure that helps it keep its shape. And that internal pressure comes from a fluid or a type of water that the eye makes itself, called aqueous fluid. This water supplies energy, it supplies nutrients to various aspects of the eye, and it's generated by a small structure next to the lens called the ciliary body. Now, all the eye knows to do is make fluid. It'll make fluid during the day, it'll make it at night, it'll keep making fluid. And the fluid is supposed to flow in a certain direction. There's a current and exit through a certain structure in the corner between the color part of your eye and the front of the eye. Now, if something happens to that drain, the eye does not know to turn down its ability to make fluid. It'll just keep pumping out fluid. And what happens then is that the pressure in the eye starts to rise. Now, if you think about any sort of container, like a bike wheel or like a balloon, as the pressure builds, at the point of weakness, you'll start to get a bulge in that structure. And the same way that happens in like a balloon, it also happens in the eye. And it just so happens that the point of weakness is here at the optic nerve. So this is a side view of the optic nerve, meaning the eye is to the right. And then this yellow structure with this red vessel is the optic nerve. And you can see that as the pressure builds, you start to get a bulging or a cupping of this optic nerve. It kind of hollows out. And this is a heads-on view. We're looking from the front to the back, and this is where the optic nerve enters the eye up top. And you see that it starts to hollow out and get thinned. And that represents the loss of important fibers or axons that connect to the brain that is occurring because of high pressure in the eye. Now, everyone is different. So even though a normal eye pressure is somewhere from 8 to 21, you cannot compare your eye pressure to your friends. Someone can have glaucoma at a pressure of 12. Someone can have glaucoma at a pressure of 16. Someone can have eye pressures of 25 and 30. They'll never develop glaucoma because of just the way the genetics and the way the eye is built. It's built to withstand those kind of pressures. So all we know is that glaucoma is a problem where the pressure in the eye is too high for that specific eye. And the way we recognize it is by looking at this optic nerve and measuring its thickness. And part of it is an examination. Some of it is also, we have some imaging studies that we can do to actually measure the thickness of that optic nerve as it leaves the eye. So how does glaucoma affect vision, right? And how can we know if it's affecting our vision? Well, we all have something called a visual field, meaning we all have an area that we can see and an area that is outside what we can see, sort of our blind spots. And glaucoma takes vision, unfortunately, from the outside in. So if you think about it, you rarely ask yourself, way up there at the top of my visual field, can I see? You just don't think about it. So it's possible that you can lose vision slowly over the years from the top down, and you won't notice it until it becomes here in your central visual field. But by that time, it's too late. So this is one of the models of glaucoma loss. And you can see here, this is a normal seeing eye in your upper left. And then you start to lose vision from the outside in. But usually no one notices that the corners are now starting to darken. By the time you've noticed that there's a problem, it's usually when you're at this point where you have what we call tunnel vision. And unfortunately, a lot of times people don't notice because if the other eye is a little bit better, your brain will basically trick yourself into thinking you are seeing. Your brain will take information from the fellow eye and make it seem like you have no issues. But if you cover one eye, that's when a lot of people notice, oh my goodness, like I have nothing left to see with. And usually by that time, when you come see the eye doctor can't do too much for you because we don't know how to reverse this. Again, these tissues are actual neurons. They are brain tissues that ended up in the back of the eye. So we know how to slow it down, we know how to stabilize it, but we don't know how to reverse it. And don't just wait until you see tunnel vision too. Glaucoma can affect, it can give you little spots or areas that are blurred or darkened as well. And so really the only way to really get a sense for if you're at risk is to be screened at your eye doctor. So let's briefly talk about the treatment and then we'll get to our last issue. So how do we treat glaucoma? And so the way we treat this is by lowering eye pressure. So again, it doesn't matter where you start. You can start at 12, 15, 20, but if you have glaucoma, no matter where you start, we have shown in our studies that if you can decrease that eye pressure by 30%, you can often stabilize some of the vision loss that is occurring. Now, unfortunately, I don't know of any natural ways to lower eye pressure. People talk about smoking weed or marijuana. You know, the impact is minuscule, and you'd have to basically be smoking continuously to get any benefit. And there's so many other problems with that it really isn't something that we employ to use to lower eye pressure. But what do we do? Well, we have eye drops. So there's a whole regimen of eye drops that one can use to turn off that organ that's making the fluid inside the eye. So it's kind of like if you have a sink filled with water and the drain is messed up, you can certainly turn off the faucet, and that's what the eye drops do, if you take them. And believe it or not, most people don't like to do eye drops. It's a hassle, it's annoying, and you have to do it daily. So some individuals, we will offer them a laser procedure. And the laser, the nice thing about that is that you don't have to do this every day. You do it once, and if it works, hopefully it lasts for a good half a year to 2 to 3 years, then you try to do it again. You try to get as much as you can out of that procedure. And when we do laser, we're basically shining a bright light of a certain wavelength at the drain. And what it does is it kicks up a chemical that basically makes the drain expand and work better. Sometimes we can also do a laser where we actually poke little holes in the drainage system of the eye to allow the eye to drain fluid better. Sometimes though, the laser is not enough. And so we've talked about turning off the faucet. We've talked about opening the drain. Sometimes we just gotta build a whole new drain. And that's surgery. So sometimes what we can do is create a small flap and make another pathway for fluid to exit the eye through the top and underneath sort of the skin of the eye. That's one way to do it. The other way to do it is actually to create a whole new drain. So we actually put a tube, we kind of take the skin of the eye down, we isolate the muscles and space them apart, and we put a big old tube on the top part of your eye, and then we make an incision on the top and slide this tube in so that it now filters fluid from the middle of the eye and back out. Now, it is a bloody surgery, and it is not cataract surgery. It's usually a good hour, hour and a half. And, you know, but we don't do it unless we need to do it. And again, with all procedures, there's always risks. And so now you have this thing that's sitting on top of your eye, which potentially could be infected. But if you don't get a tube, at some point that pressure will build, and then you have what we call snuffed out vision. It'll affect the optic nerve to a point where your vision goes to what we call no light perception. You won't be able to see anything. So you're really stuck between a rock and a hard place when you're at this point. But if your doctor recommends you do surgery and you want to keep your vision, then by all means, that's the option with which you have to comply. So again, because we can't reverse this, the screening component is key. If you pick up anything at all from me today, what I want you to walk away from is that eye doctor who sits there and takes my money, he's doing something. He or she is providing a service. And it's important that I check in at least once every few years. And we'll talk specifically about how often you should be seeing your eye doctor. All right, the last topic before we open up for some questions. So this is last, but definitely not least, is the dreaded diabetes. So I am not going to spend a ton of time talking about diabetes, the way it's diagnosed, all the criteria. I'm sure that someone else will cover it and there's a lot of overlap. But in general, most of us are familiar with this condition, unfortunately. And it's a condition where the body's ability to utilize sugar is impaired. So in a non-diabetic individual, you eat something with carbohydrates, it gets broken down in your digestive system, it enters your bloodstream, and it goes to the cells that need it for their energy. In a diabetic person, that process is blocked or it's impaired. So that sugar can't leave those blood vessels. So what does it do? Well, it ends up hanging out in the blood vessels, and then it actually changes some of the structures on the red blood cells, and then it makes those cells toxic to the inner lining of the blood vessels. So it basically destroys the lining of blood vessels, and it affects smaller blood vessels more than it affects larger blood vessels. So if you think about, where do you find small blood vessels? Well, unfortunately, you find them everywhere, right? So this can happen in your kidneys. This can happen in your heart. This can happen in your nerves. It can happen in your brain. It can also happen in your eyes. So that's why diabetes is such a problematic condition, because the structure that it affects is literally everywhere in your body. So this is something that in America, 16% of Blacks, so people with melanin or people of African descent in the diaspora, have diabetes. So if you go to a Black church, again, 200 people, 30 something of them have diabetes. Okay. Now I know that some of you are saying, well, that's before no, yeah, we're from Ghana, and the diseases of Egypt will not afflict us. So if you look at studies, and this is from a 2009 survey that was done in Ghana, the prevalence of diabetes in Ghana, and this is a conservative estimate, right? Meaning it's likely higher, but this is a number that came up with, is about 6.5%. Now you may say, oh, this isn't too bad, but if you go to Accra, or if you go to some of the more urban or heavily populated centers in Ghana, that percentage reaches actually close to 10%. And again, if you think to yourself, well, because I'm free Ghana, I'm not likely to be affected by this the way the way they are affected. You really have to ask yourself, one, how much of a Ghanaian are you? In this country, your lifestyle, your job, your stress level, the way you eat, the way you participate in activities, and your activity level, your disease profile more resembles an individual who lives here than it does your family member back home. And so with lifestyle, and so the point is that even though genetically you're a Ghanaian, you have to think of yourself when it comes to these conditions as almost like a Black American in the United States. And so if you think about it that way, even with conservative estimates in our own population, most likely we are sitting somewhere between 10 and 15%. So again, that means in a church with 300 people, 30 to 35 of them are going to have diabetes in a conservative estimate. And the catch is, just like glaucoma, approximately 40 to 50% of them don't know it. So either they have not yet developed the symptoms that go along with diabetes, or they have the symptoms, but they're unable to recognize them. And the danger there is that you don't have to know that you have diabetes for it to be affecting your vision. And so I wanted to look more precisely at just how diabetes messes with the normal process of seeing in the eye, just so potentially you may be able to recognize some of these symptoms, or at least if you have a condition or you know someone who does, you can encourage them to take it very seriously. So this is a normal retina. So when I or another eye doctor looks into your eye, this is what we see. So this orange area is the retina, and all these kind of branching curvilinear structures, almost like a road, are your arteries and veins that are within the eye along the retina. This yellow structure right here is the optic nerve. That is all those million fibers that are carrying messages from the eye back to the brain. This is the picture of a healthy, normal eye and retina. Now, we talked that diabetes, when it starts to affect the eye, the first thing it does is that it damages the blood vessels. So this is something we call mild non-proliferative diabetic retinopathy. So in these mild changes, the first thing you notice are that you have these small, what we call microaneurysms. So these blood vessels develop these balloon-like pockets of blood that you can pick up on the exam as these red spots. Sometimes those red spots burst and you get little hemorrhages. Now, if the hemorrhage is small enough, it won't really impact the ability of light to hit the retina. So you don't necessarily know that something is wrong. But for every blood vessel that bursts, there's an area of the retina that is not receiving the kind of blood that it needs. If you allow this to continue, then you reach a stage called moderate non-proliferative diabetic retinopathy. And in this case, now you're starting to have larger spots, larger areas of bleeding. Then you start to get little areas where the retina is shocked and starving for oxygen. Remember, the whole point of blood is to bring oxygen to cells that use it for fuel. And so if those blood vessels are bursting, then there are some cells that are no longer getting that oxygen, and those cells become starved and they turn white, like little cotton wool balls on the retina. So when we see this, we start communicating to your other doctors that, this person is seeing changes, and that means their blood sugar is likely not being controlled. Even if you think your A1C is doing fine, or you think that you're doing fine according to your blood sugars in the morning, this tells us that whatever control you have is not enough and it needs to be more. Now, when things get bad, you can develop what we call severe diabetic retinopathy. So in this place, now your eye is sick, right? The eye is suffering from poor blood flow. Even at this stage, you might still be seeing okay. You might notice like there's a few areas that seem, who I did this the way I used to, but most people, even at this stage, can shrug it off. But a lot of irreversible damage is starting to occur. So you notice you're starting to develop all these curly, wavy, kind of fragile blood vessels. And the reason the retina is generating these blood vessels is that it's starved. And so it's trying to create more avenues or more pathways to get blood to these starved areas. The problem is that the best time to make blood vessels is in utero, in the womb. Once you leave that environment, your body's ability to make blood vessels in the retina is severely compromised. So the kind of vessels that the body makes are fragile, they leak all over the place, they break, they grow in the wrong areas, they cause problems. So when we see it at this stage, this is frequently when we kind of panic, and sometimes we may start treatment. And the treatment, if you think about it, we need to get medicine that's outside of the eyeball into the eyeball. And so the best way of doing that is sticking a needle into the eye and delivering that treatment. And sometimes some people need it as often as every 2 weeks. Some people need it every 4 weeks. Some people can space it out a little bit. It just sort of depends. And that treatment in itself is kind of temporary. It only can make those blood vessels go away for a few weeks at a time. But if you don't get that sugar under control, then it'll continue. And if it continues, you can get this. So this is what we call proliferative diabetic retinopathy. And this is not just bad, this is dangerous, right? For the risk here is that you've had a large blood vessel burst, and now blood has left the vessel and is now sitting in the eye. And so yes, one bad thing is that it's blocking the ability of light to go back there. And so your vision severely drops. And we call this a vitreous hemorrhage, meaning a hemorrhage or a bleed in the vitreous, which is the gel-like parts of the eye that sit in the middle. But the problem with blood is not just that it blocks vision, but blood outside of vessels is toxic to the eye. So when the blood goes into the eye, it brings other substances that are coming along with it. And those substances can cause fibrotic changes in the cells. And it causes a scar-like tissue to grow over the retina. So this scar-like tissue develops almost like a scab over really vital structures in the eye. And then the scab starts to contract and it pulls on the retina. And so it pulls, and eventually it pulls so much that it actually yanks the retina off of its foundation on the back of the eye. We call that a tractional retinal detachment. And you can imagine there's no eye drop or there's no needle or injection that's going to fix this. So the only way to fix this is to go to the operating room. And when we say fix it, what we basically mean is we can put it back together again so it looks nice. It doesn't mean that you're going to have the same kind of function of vision that you kind of had before. And the scary thing about this kind of surgery is that if you reach a point in your disease that you need this kind of surgery, it's also a really bad sign for your longevity. So 50% of individuals who undergo surgery for a tractional retinal detachment, so this is a specific kind of detachment associated with diabetes, 50% of those people are dead within 5 years. So you really don't want to get to a stage where you need this intervention, because by then it means not only is this problem so bad in your eyes, which is just a window to the rest of your body, actually the problem is wreaking havoc all throughout your body, particularly in your heart. So you'd think that given this understanding, diabetics would be good about seeing their eye doctor. But actually, again, 50% of individuals do not see their eye doctor yearly as recommended. And those are the individuals with diabetes. So why is it that people tend not to see their eye doctors? Mostly because you can have this condition progress and you can have no change in the way you see. But just because you're not having a change in the way you see does not mean that changes are not occurring in the tissues of the eye itself. And so sometimes when we treat you not necessarily because you're having a vision issue, but we're trying to prevent you from developing a vision issue, or we're trying to delay the process of vision loss. And again, the options to manage this really decrease when you develop an advanced form of this condition. So if you have diabetes at all, mild, moderate, severe, you should be seen yearly. And the reason you should be seen yearly is because of what we just discussed, but there's also one other issue which can happen at any stage of your diabetes, whether it's mild, moderate, severe, proliferative, or non-proliferative. And that's something that we call diabetic macular edema. So as you wind down, this is a picture of the retina flipped so that you're looking at slices through it. And so what you see here are the retina is actually composed of maybe 7 or 8 layers of cells. Light hits the bottommost layer, connects through these connections, and then speeds off into the optic nerve back to the brain. This is a healthy looking retina. There's a nice little dip in the middle, and this part is responsible for your clearest central vision. I mean, this is a part that allows you to read those small, tiny letters. And so the same way that diabetes causes leakage into the eye, it can also cause a swelling in the retina itself. The blood can burst, leak into that retina, that thin, delicate tissue at the back, and then cause it to look like this. So what it's done now is that lipid, serum, fluid, fatty contents, and blood have infiltrated that space and expanded it like a sponge. And whenever that retina is swollen, your vision is going to degrade. And when the vision degrades, it leads to images and appearances like this. So centrally, you'll notice that things are really blurry, but maybe in the periphery, they don't seem as bad. And the issue with this is that it can become a permanent thing. So it's kind of like if you allow fluid to sit in your basement and you decide a year later to clean the fluid out, sure, you can get the fluid out, but some damage has occurred to the structures in the basement, which can't be repaired. In the same way, again, we're dealing with essentially brain tissue that ended up in the back of the eye. So when you allow water to just hang there for too long, it can cause irreversible changes in those cells. So how long is too long? We don't know. And so that's why it's important to get looked at whenever your vision is starting to get blurry as a diabetic, because we don't know just how long the fluid has to hang around before it causes permanent damage. And the way we treat this is, of course, with an injection. Again, these injections can happen anywhere from every 2 weeks, every 4 weeks and it can happen when patients ask me, how long do I have to do this? And I just tell them indefinitely, which basically means it can happen forever. And so if you can avoid it, you want to try not to get there. And I wish I could tell you that it ends here, that these are the only problems that can happen from your diabetes, but unfortunately, it does not end there. Diabetes can lead to glaucoma. It can also cause cataract changes. It can cause the lens not just to develop a cataract, but to swell itself because of all the blood sugar and the osmotic changes. And that can affect the way the lens bends light, which can make things really kind of foggy for you. And a lot of times when individuals go see an eye doctor and the prescription seems to be changing, like one time it's a little bit negative, then it changes. Sometimes it's actually your blood sugars that are messing with the lens and its ability to bend light. And so the measurements continue to kind of waver and be off. So, the takeaway from this is that many people believe that the reason to see an eye doctor is when you're having problems with your vision. And that is one reason to see an eye doctor. But many of the diseases that I treat, they don't have early warning signs. And so you can lose a significant amount of vision before you even realize it. We didn't even talk about retinal detachments today or flashes and floaters, but that's why it's important as an adult to see an ophthalmologist for regular eye exams. And so the recommendations are, at the age of 40, everyone should have had at least one eye exam. And if you get a clean bill of health, if your eye doctor says your eyes look pristine, come back in 2 years. Not 3, not 4, come back in 2. Once you hit 55, you want to try to be doing this every year, even if you have a clean bill of health. Certainly, if you're 65, it should be every year so that we can catch, because as you get older, things start to break down. Now, if you have any eye problems, all that's out the window. I mean, at a minimum, if you're diabetic, whether you have an eye problem or not, you've got to be seen yearly. And depending on the level of diabetes you have, we may see every 3 months. So it just kind of depends on what conditions you have, but at least at minimum, once every 1 or 2 years is what we think keeps people from missing that window of opportunity. So again, the best way to prevent vision loss is to protect it early. There are things that we can replace. We can replace, people have done hand transplants, people have done liver transplants, kidney transplants, even heart transplants. The two things that we can't replace. We can't replace the brain and we cannot replace the eye. And so, God gave you 2 of them. So you want to do the best you can to keep them. So I'm going to thank you for your attention. That was pretty much all I prepared today, but I'm open to taking questions or anything that you guys would like to discuss. So I think we can open the floor now. And if there are any questions, I'm happy to answer them.
Oh, Dr. Thompson, there was a pa and na additional. I had the pa a. I'm just say in papi so awesome bisa at the mouth. It is a person here ni wasn't bisa with me apija onsa and now so with me a typing or chat or you be ready. anaasɛ wobɛtumi nso no aba so na ɔbɛbisa wasɛm bisa no sɛ dɔkta kaa no ɔyɛ kyerɛ mu no ka no pii ɔborɔfo deɛ nanso wasɛm bisa no ɛnyɛ fɔ kyena busa no borɔfo wobɛtumi bisa no twi ɛmfante ga ne nyinaa ɔte ne nyinaa ɛnti deɛ ɔyɛ comfortable biara no na ɔyi so bisa no question no na waboa kyekyere mu ama yɛ wɔyɛ dɔkta ansa na obi bɛba so no ma menka ntia no obi asɛnde me the question ɔse ɔwɔ akwadaa na akwadaa no ɔbɛda sɔre biara na n'ani ayɛ kɔkɔɔ ɔde ka bɛkɔ ɔyi hospital onim pako ɔhwɛ sɛ ɔyɛ optician sɛ ɔyɛ ɛyi ɔnde onim but pako no ɛma na eye drop de gu so so saa na akwanda na so ne ɛkɔ no ɛyɛ effect bi na ɛkɔ so anaasɛ ɛyɛ dɛ ɔdɔkɔɛ no wasɛ brɛ musa mu yɛdeɛ but the concern no
Sure. Yeah. So, and saw red eyes. Rafono, you kind of say for differential on just the potential causes for say, a dorsal P. And it a bayadin said me pinpoint one ABR. It's me I can say a way, but what I can say is usually. Akada enya sa red eyes and all. Sometimes a bit to me I get allergies. It could be say ABI there was some irritant BI. I want a pillow and I say a bed sheet and I say even the exposure to a buntini. But to me I'm on the eyes and I get red. Particularly say or rubbing the eyes and all. Say a hano. And see a bit to me about the redness. Every the rubbing actually. You see, ABI will feel it irritated and now say he's itching until rubbing the eyes not a massa blood vessels no eye engorged and then looks red. But you might kind of say, even though to me it is not threatening his vision, it's just say uncomfortable and now say it looks AEB, but it's not something that affecting his sight. And the right thing. I'm not sure who you saw, whether a optician or ophthalmologist there, but most of the time, as far as red eyes, anyone can look at that and get a sense for what's going on.
So that's hopefully the Pagano at Yasia. Well, the Obi Busalansa, Obi Pijanesa.
If you are me, also what?
Patrio Azmara, Patro, with the question, this your papa, Nasi your mammy. And that's all announced there.
I told me that's it. My question here about Aqueous so 4 or 5 years.
Okay.
And he are diagnosing with cross eye. Yeah, what will go through treatment. Yamani glasses ne. And person Busa who say, is it likely for him to grow out of it? And I say, how is it?
Yeah. That's it. It's a very good question. And to saw cross eye no. Usually, what it means is that one eye is weaker than the other. And usually, the way, say, a cassette and eye is weak, all it means is that they have different lengths. And the strength of an eye usually relates to how long an eye is. And even though we were 2 eyes, every time I said the same way, OB9 is 11 feet. Now, the other fellow 9 is size 9. The eyes can be different too. But when the eyes are too different, the messages the brain gets from each of them, the brain cannot put them together. So it turns one eye off. And if that eye stops being used, and it can turn out, it can also turn in. So many times what we'll do is we'll patch, sometimes they'll put a patch over the stronger eye to force the brain to engage the eye that is turning loosely. Most kids can't handle a patch, but it's your job as a parent to try. Sometimes it's so bad that the muscles have now become weak. And to actually do something called muscle surgery, where they go in and they cut the muscle, reattach in a certain direction to bring the eyes back together. Now, the question you asked, and this will they grow out of it? There are some forms of cross-eyedness that particularly occur early in life that you don't have to worry about. So anything before 4 months, A client and they'll just look in any direction, whether they're normal or not normal, because they have not yet been able to coordinate the eye movements the same way the child will have issues coordinating their fine muscle movements as well. But it's unfortunately, you don't know which one the child will grow out of. And see, that's why it's important to see the eye doctor. They'll make measurements and get a sense for how bad the eye deviations are, and they'll follow them. Sometimes we don't know ourselves, so we'll just follow them, and if it gets to a certain point, we'll intervene.
Okay. If I show me say where you are no kakra mamina. I'm worried kakra say we've done the patch, we've done the atropine glasses and stuff like that. It's still, we're not seeing any improvement. It's not a little bit worried now.
Now, how long have you done it?
We've done it for about 2 years now.
Okay, and what does your eye doctor think about that? What kind of thing?
She said he might grow out of it. She doesn't really know, so we should just keep doing what we're doing. I'm a little bit worried. Yeah.
Yeah. I mean, so I'll tell you, it's a difficult place because once you've done patching and you've done the drops that change the way the eye bends light, you've done the glasses that are supposed to help correct the differences in the way the eyes are seeing. In fact, you could do surgery to bring the eyes together, but again, it's not about the eyes being aligned, it's about the eye seeing well that will make it aligned. And see, out of those, you're really limited as far as what else you can do. Sometimes too, all it is just a kid will have these interventions, and because of the age they're at, they won't start to show any improvements, but then later on, you actually, either you've prevented them from getting worse, or you start to see the changes pick up. And even though it sounds, it's a cliche statement, I mean, what you've done a very good job, and you have to keep doing it. Because by the time a kid gets to 6 or 7, that's when you'll start to see, particularly when they start to read, they can start to tell us what they're seeing. That's when you'll be able to know, what you did had an effect or not.
All right.
Okay, that's it. Dr. Swimmer was a no, me question in me. Say, oh, can't say 3 topics, I say cataract, no, can say, be now blood, a vessel, no eye, the back of your eye, need to me a bust. Inti a bassa, itimima, winner effect be. Now, dear, me, tear say, and say, blood vessel, no bust here. Right away, no, it shows symptoms. Anyone who say, "Beer, this is what has happened," and now say it takes some time. The answer effect, a show when the invisible.
Okay, and see, you saw a question. There's a 2-part answer. So one answer is it depends, and see, in general, the blood vessels in a diabetic hypertensive eye, meaning an eye with diabetes, and I said with high blood pressure, they're likely to burst, but in small ways. The same way a very small bleed. And the same way you can really have a cut, just a gaping wound. The same way you can have a different degrees of bleeding in the eye. And yes, when you have the bad kind of hemorrhage, immediately you notice a swirling and your vision won't come back. Wow, we'll call eye doctor. But you can also develop slow bleeds where you don't pick it up, but the blood is still infiltrating in the eye and causing those scarring changes. And possible.
Doctor, paying for Jensen here. Sure. No problem.
But yeah, what chat so now will be besides what causes tumor behind the eye, and what are some of the signs we shouldn't ignore when it comes to tumor behind the eye?
Okay, and there are all sorts of tumors, and I said growths that can occur behind the eye. Some of them are vascular growths, changes in the blood vessels that can cause changes. Some of them are growths in the muscle itself that can constrict the eyeball. And some of them are growths in the bone as well. And to me is under the category of a tumor behind the eye. The signals that you shouldn't ignore are one, pain. And so when you're excessive pain, what we call, your friend has said, unrelenting, meaning we are and koda. And you don't need to be waiting weeks and weeks. Just say it's been there for 1-2 days and it hasn't let up. That's something that you need to see an eye doctor about. So we'll notice it, say, you're having double vision. It means that in the back of your eye has pushed things forward so much that it's constricted the ability of the eye to move. And when you look one way, you're seeing two images. That cannot be ignored. If you notice, I said one eye is more forward than the other eye. That is also something that can't be ignored, because that again means that whatever process occurs behind the eye, it is so forceful extruded the contents of the eye forward. And you see some people, it looks like one eye is more forward than the other eye, and then the eyelid looks a little bit kind of stretched and tightened. None of those things should be ignored. So those are what we call the cardinal signs. But I'll tell you, a tumor behind the eye is pretty rare.
You said the plastic at your say, but the message my Eda Abaso.
Doctor, that's a pa. I said, well, my near get me. And said, yeah, can not on boy organs for a note. There was a period of time when no one may organize for first Ghana. Or someone on Beshenity. By the way, allergies. Yeah, my itching eyes, sweaty eye, long-term allergies, a bit meaning a long-term effect or an issue, vision, so severe. It's me a boy.
Yeah. And see, allergies, it's the same allergic reaction across the wall, your nose and your throat. That itchiness, discomfort is the same antihistamine release arousal in your eyes. And actually, it's not the eye as you know, but it's the eyelid. And if you take your eyelid and you lower it behind that surface of the eyelid, those are all potentially surfaces that can be irritated by allergens. And so frequently they will give you eye drops and tell you use it twice a day. And it's something that we call symptom control. Just that, we cannot remove the allergy from you. All we can do is take you away from the allergic exposure, or we can suppress the response of the tissues around the eye to that allergy. But the question you ask, will it have any long-term damage? No. The traditional seasonal allergies that people experience here in the States are not the kind of things that will cause long-term eye damage. But it will be annoying. Yeah.
Oh, that's a pa.
Opinion so that's no question busai. Any patro my what may busa say. Now ka say any eye transplant. Now the intina idunity eye.
Yes. So it's good. So what be a good question. So let me be more precise. There are the part of the eye to me transplanted is the cornea. Okay. And so the cornea is the frontmost part of the eye, this clear as a curved tissue bead. And people can get these changes in the cornea where it becomes scarred. If you have an injury, you get hit in the front of the eye, the tissue will stop being clear and become scarred. And I say if you get a cut. And sometimes we'll take that cornea away and we'll take a dead person's cornea, match it, and suture it together. But it's not a full eye transplant, it's just a corneal transplant. Sometimes too, we can take tissue, like the eye wall, it's called the sclera. We can take bits of that tissue and use it to cover defects in the eyes that we do surgery on. So those are mostly the reasons why we take eyes when we donate it, but we don't yet know how to do a transplant, and we probably never will.
Dr. Darcy, you said
thank you. Matthias, thank you very much.
Okay. Eddie and Pacho, 5th Avenue Smile. You said a bear, Dr. Seltitua. You said Pacho with Nabaso. Okay. On your ready, dear. And the Enfre Samsung Galaxy 7. S7.
Yo, Fedasepa, opinion. Doc, Nyame H. Me were two questions. The kind no. Nancy na me ko me eye doctor na or the omame glasses na me shecha na ma me feel me tie me yakakra. Enti ma me feel comfortable say me share ne time bia. Second, pese me hu say ye mai ne ye maame no mo no. Eye enwi omutita wo mani no ebetimi ama wo problem future na. That's it.
Wait, Doctor, a question me so chat no best and ya bremi. Anyway, ask them if I can't pronounce the name you know. Also, we say eyeliner and a year man of the care come when you ask you know, a bit effects or money so ana. If I can't eyelashes in my that's it.
Penny, you want to get me in trouble. Okay, let's take the first question. And TM said, the first question is the glasses. Okay. So the glasses are designed to correct your vision. All that means is the way light is being bent is in a fashion where the image that gets projected onto the back of your eye is blurry. So the glasses are trying to adjust and compensate for that so that the light bends correctly. Okay. Now, sometimes when your eye doctor makes glasses, in fact, they just get the prescription wrong. And everyone has a different degree of tolerance, right? So for some people, you can give them a slightly wrong prescription, but their vision has improved. They don't seem to say, no man, how, and they're okay with it. It being soon, you're very particular. Just say any small deviation, they will pick up. Some call for no people who are engineers, people who are very picky, they make their beds every morning. There's a personality style for this as well too. And what I was saying is that I don't know your personality, but either way, if you notice that it's hurting you, it probably means that it's not the right prescription for you. And it could be something as simple as maybe a few changes. The reason why it's a problem is that it can be expensive. And sometimes your eye doctor may not want to adjust. You know, to be honest, doing the glasses, the actual exam pays very little. And so what I would suggest is that when you get your prescription, you ask the eye doctor for the actual numbers. There'll be 3 numbers. And then you ask them for the distance between your eyes. All those things, they're legally bound to give it to you if you ask them. Then instead of going to Lens and Crafters and spending $200, $300, $400 a nice pair of glasses, what you call it online or so, you can work with call a Zenny Optical, I Buy Direct. That's where I get my glasses from. We'll be chat $10, $20, $30. And that way you can try it. I mean, the quality is still the same. I mean, the lens, the frame itself, you know, ABS a poor quality, but the actual lens, there's no difference. And if it works for you, your expensive one. And so that's one way to kind of get around that. So yeah, again, it won't hurt you, but it will be very annoying for you. And so if you tried it for 2 weeks and it doesn't work, you got to take it back. Oh, okay. You have a question? Yeah. So I'm gonna say this. In fact, the eyeliner, it can cause what we call meibomian gland dysfunction. But I'll tell you that there are lots of things that can cause problems. People still do them. And so, yes, it's true. It can sometimes, the wrong kind of eyeliner can sometimes clog the glands in the eyelids that make tears and that make oil and that make your tear film. But it usually doesn't cause a kind of lasting damage that will affect your vision. But when I look in the eye, I'll notice that, oh, this person, their eyelid glands aren't working, don't look too healthy. And sometimes we'll tell people take a break from it. But, you know, is that a reason to avoid it completely? You know, that one day, I'm not sure. So I can't hold on, but yeah.
Okay. Now, obusai for eyelashes also.
Eyelashes, yeah. See, I'll say so. People seem to like long eyelashes for centuries. This is not way in your new ABBA. Apparently, you can do glue, you can weave and suture them on, and it'll affect your own eyelashes. But unless one of those eyelashes comes off and gets trapped in your eye and causes an infection, it's unlikely, because even when it comes off and gets in your eye, you feel it and kind of wash it out. And so the risk is minimal. I mean, the real risk is people who keep contact lenses in more longer than they're supposed to. That's the one that we see too much of. Yeah.
Okay, Dr. Edwasi. And then Pacho, Niparan iPhone no bet me abaso. We are near chat na so.
Hello.
Pacho bet makasa.
Hello.
Hello.
Pacho kasa.
Me kwasani. Dr. Kasano, diabetes. Man so waka say ebia wonu nsu a wonsu nya utimi nya ni yare ana so nya accident a utimi nya ni yare na say no de enka ho bi na fe so ye surgery ye no ba akwa na obetimi aye mienu ana amiensa madam ase.
Okay. Until Penny Patrick, me pese me to a question I see here. What can say insurance, meaning in America, usually a better unlikely say either tap water and I say filtered water. But to me, that would be the only thing I can think of. And it's ABI. I'm trying to say you go swimming in a lake B and you swallow some water. What's some parasite? Yes, there have been instances where I saw a parasite. No, I bet to me I called bloodstream and ended up in your eye. Again, very rare cases. But I think in general, I don't think the water that we drink is a risk to our eye health. There may be reasons why potentially people should drink different kinds of water, but it has nothing necessarily to do with the eye. And the second question is the surgeries. Well, I'll tell you, in medicine, there was some phrase just that if you go to a surgeon, the answer will be surgery. You bet me to try with Nisa. We can actually take it to the operating room over and over again, but the eye itself, to be honest, can't withstand so many surgeries. Usually by the time you get to round 3 or 4, it's game over. And sometimes we'll even tell you, if we take you to the operating room again, the eye will go kaput. Just the eye, there's a state called where the eye basically gives up, it stops producing fluid, it deflates. And then it just becomes a painful, shrunken eye. And that can frequently occur after enough surgical intervention. So yeah, ideally we get it right the first times.
Open your question and answer. And doctor, I chat so nobody will say a safe. Opinion a safe set after the age of 70, obey surgery, and remove cataract.
Yeah. And to cataract surgery, and you have to say, giving birth, you can do it anytime. And in fact, routinely, you're doing Crawford in the 80s, 90s, 99 cry. Yeah. And now the question is, if you're 99, you probably don't have too many years left. But even then, it's worth it, because even if you're demented and you're blind, you have a different kind of lifestyle than if you're demented and can see. And so even for individuals who may have problems with giving their permission, frequently, people who are responsible for their guardianship will actually assent for them to have cataract surgery. So yeah, I would say age is not a problem here. Yeah.
Okay. Dr. Edasi, since it will be Mamin Picket or more Pija or Masarabako. 1+8T 5G. Probably to a question.
And so, sir, Kwamba no Mabusami question.
Patch your opinion. 1+8T plus G in your ready dear.
Hello?
Hello, Pacho Casa.
Sorry, I was on mute.
Oh, okay. No problem.
Hello, Dr. Ian, your childhood friend, Jennifer. Nice to see you.
Hey, that's the same.
My question, my daughter is 9 years old and just a few years now that school eye exam, she kept failing. So I thought for a while she was just goofing around and they just failed her for whatever reason. I don't pay attention and didn't really, I thought, oh, only problem beyond. And then just recent, about a year ago, took her to an eye specialist and they said that she had astigmatism on both eyes. So my question is that she was then prescribed for glasses. How long is the correction? I know you said several times that glasses is to, help correct the eyes and so forth, but how long is the whole process out? And I say, how long I'll be shed glasses from being 9 years up until when?
Yeah. So Jennifer, one, it's good to hear your voice. It's been a long time. So the astigmatism means that instead of her eye and cornea being shaped like a sphere or like a basketball, it's shaped more like a football. So the curvature in one dimension is more intense or pronounced than the curvature in another direction. Usually when people have astigmatic changes in their eyes, they don't grow out of it. It's not a big deal though, right? Because I mean, I wear glasses, she will live, but it's probably not the kind of thing that she will grow out of. And it's better for her. It's kind of like, so long as the glasses get her to seeing 20/20, no problem. In the future, if she wants to have surgery to be free from glasses, not as a kid, but as an adult, that's also an option for her as well, certainly. But I think, what you're looking at is pretty much, she'll be wearing glasses for some time. Yeah.
Oh no.
I don't unpack glasses.
She had a rough time in the beginning, but now she wears it and forgets to even take it off when she goes to sleep. But,
it means she likes it. Yeah. Well, mine stylish glasses, crap. She'll love it.
And I'm sorry, I thought I finished, but quick question. Sometimes it's all sitting the eyes and they're itchy, and then she start rubbing it. I don't know if it's again allergies or just from the glasses. Or to me, you said Nina face like also watery.
Yeah, so if it's watering, right, then it probably means there is, and Karadia, I mean, sometimes my daughter would tell me and say, oh, Dad, my heart hurts. Just that, I mean, it's hard to know what really is going on, to be quite frank. But I was saying is that if you notice that when you give her attention, the next day she's okay with it, I wouldn't worry about it too much. Anything that's going to cause a problem won't go away. It'll remain. And it's probably true that her eyes are itching, but it's also probably true that whatever it is, it's not going to be of very much consequence to her vision.
Okay, thank you.
No problem.
Okay, Pacho, Eda, what was our question?
Dr. Thompson, opinion Usuni.
Hey, opinion to say.
Boko. Now, person me who to say any yare no wo fie. Obusiafo no omo ewo any yare no. Nti at what point in the beer to say a person like myself no, who person will call ye surgery say won't share glasses bio, and is it possible na here? And I say you wear glasses or life
I'm say glasses now. I can see say hygiene. So Uncle, what I was saying is that for you, Mikai said, now with your glasses, you have some very stylish glasses, Mikai Pa. I would say that you do have some options. So surgery, especially cataract surgery, a elective, and to just say, yet, you can also not do it. And the reason it's elective is because a set or B windshield. People have different levels of tolerance for dirt on their windshield. Before for so car no windshield I seen, and both people would say nah, it's fine. In the same way, someone can have a really bad cataract, but I said, like, or to me on the baby, or it doesn't really bother him. Or be so you will see, look into their eye. It was a small cataract B, but just a complain this and everyone is sort of different. And I'll say most of us at this stage, if you want to get rid of the glasses, I mean, cataract surgery, and you have cataract surgery would actually be a really good option. And I think that if you have a competent surgeon, there's really no reason to avoid it. When it's time for me to do it, I'll do it and be happy to do it. I have that much confidence in the procedure. But again, only do it if you think that you'd want to see better and would make your life more enjoyable.
Difference between only LASIK,
LASIK, so the difference is that cataract surgery, they go into the eye and they take out the lens. LASIK, in this set, they actually shave the front surface of the cornea. They shave it to change the way it bends, because in the eye, the lens bends light and the cornea bends light. So you can go in and take the lens out and put a new one in, or you can change the way the cornea is shaped. What I was saying is that the challenge is that if you do LASIK and you change the way that front surface is shaped, but the lens itself is still cloudy in your one because the light is still having problems getting back there. And in that case, the argument would be it'd be better to take the lens out than to do LASIK. So usually at this stage in your 60s, LASIK is rarely of much benefit, because the thing that's probably impacting you more is the lens itself, not the corneal curvature. Yeah.
Is there any danger why you're blind?
Well, the risk for infection, if I recall correctly, is about 1 in 10,000. So that means, actually, no, sorry. It's 1 in 40 or 50,000. So that means the major risk is that anytime you put something into the body, you potentially can bring something that's outside the body into the body. The same thing with the eye. And when infections take place in the eye, they are hard to control because of some of the natural properties of the eye itself. If you get infection, it can sometimes end up in pretty serious consequences. You can sometimes even lose the eyeball. Again, it's very rare, okay? And it's nothing that you did wrong or anyone did wrong, but that is usually the risk for vision loss. Yeah.
In this case, not just a glasses no cry, send you oh, and your fee now to be pim say we are not just a local.
Well, I kind of say, if you come to an eye doctor's office, a good one, and you say, cataract surgery, I will tell you, call with glasses, do it again, and then come back to me if it's still a problem. Because you're not happy with your glasses, because you're right, surgery is still surgery. Nothing is ever foolproof. But there are some cases where the glasses are not doing well for you, and in that case, you might as well take the lenses out.
Okay. All right. Thank you.
Okay.
Okay. There was no question. About chat, so Dr. Obi, which I say, a friend of Mary, which I say, what does it mean when my eyelid keeps twitching?
Yeah. So Mary, so your first myokemia or myokymia. So basically, what it is that there's a muscle in the eyelid that the nerve is firing, and that muscle is twitching. Again, this doesn't affect the vision. Sometimes it can make your vision shake a little bit. And usually it's transient, meaning there are some triggers. So one trigger people have identified is alcohol. Another trigger is caffeine. That includes chocolate as well too. And so if any of these things are kind of in your lifestyle and the twitching is bothering you, then it might be good to take them out sometimes too. And yet anything anyone can identify. I think that there are things in medicine sometimes the answer isn't said. Honestly, we don't really know. But what we do know, we have a good sense of the things that can blind you. We don't always know how to explain some of the other changes. And so if it's not any of those, if you can identify things that you eat, sometimes you can pinpoint one thing that can maybe causing this. But if you can't figure it out, I wouldn't worry about it too much.
Pacho, any matter also, I wouldn't understand the question, you know.
Okay, Mpacho, my question is, Uncle Joseph kind of touched based on exactly what I wanted to ask, which was in regards to the LASIK eye surgery. If let's say you're in your early 30s, you depend on your glasses or contacts, is it really advisable to do that? Or just write it out and keep wearing your glasses and your contacts? And also about the cataract surgery, if you do one and it ends up going bad, is it advisable to go ahead again and do another one, or with that one you can do it again?
Yeah, so in your early 30s, so the challenge with LASIK is that, so I'll give you an example of me. I'm in my mid to late 30s. I am nearsighted, meaning I see better up front. Just I have a very light prescription, right? So I could potentially get LASIK and correct my vision in the distance, which would be beautiful. But then what's going to happen is, as I get older, my ability to see things up close will decrease. And as a surgeon, I need that ability. So for me, it doesn't make any sense to do LASIK at this point, right? And so a lot of it comes down to your lifestyle. If you're Tiger Woods and you're, a fighter jet pilot, then you should probably get LASIK. If you're kind of annoyed at having to put in contacts every day, LASIK is an option for you. But the question you have to ask yourself is, what will you be doing with your vision in your 40s and your 50s? And actually, I would ask the doctor, I would say, because you can get LASIK for being far-sighted, you can get it for being nearsighted, and I'm not sure which one you are, but I would ask your eye doctor, like, what will this change about my ability to do certain things in my 40s and 50s? But if you're only worried about, I just want 10 years of good, clear vision, yeah, LASIK will work for you. The thing that people complain about is that sometimes it can cause dry eye, which means it can make your eyes real sensitive, but you put in a few drops, most people are happy putting in drops for the enhancements in their vision. And if you're gonna do it, you do wanna do it now. You don't wanna do it in your late 30s.
Got you, thank you.
Yeah, oh, and cataract surgery, and so if something goes wrong in cataract surgery, you do wanna have a very clear idea of what went wrong. And so what I would do is, a lot of times we'll see disasters. And the community in general, no one's going to tell you, say, hey, Doctor, no, you messed up. No one's going to tell you that. No one's going to, it is a very courteous, professional community. But you should actually get a second opinion, and you should say, I want to understand, is the thing that happened to me the kind of thing that happens, or is it unusual? Those are the words you use. And then you get a sense if someone messed up, or if someone says, oh, it's unusual, then you got to worry that something happened. If someone says, no, it happens, then maybe it was just bad luck. If it's bad luck, it might mean you have the kind of genes or the kind of eye anatomy where it might be difficult to mess with. But we always hesitate if one eye went bad before we do the other eye.
Okay, all right, thank you.
Oh, Mate, there was no question I would say. Mr. Say, time no continue. A bit may say no, be one question. So in a bit me, I would say, Bisana. Doctor, already make up chat, so no, be beside a mammy Elizabeth. We say, Kohun ne eye doctor recently. No chance to obey the left eye surgery. If we say the drainage system is narrowing, no, so who say a serious surgery and a be serious. Now the condition is serious.
Yeah. So it looks like she has some kind of what we call canicular stenosis. I'm not sure. There are various drainage sort of ports in the eyelids. And if it narrows, one thing can happen is you can start tearing a lot. Usually we don't do surgery unless you yourself have complained that there's a problem. So I would say that if you notice that you were tearing a lot, it was getting, making vision blurry, you can't do the things you like to do, and you went to see the doctor and he said, yeah, the drain is small, I need to enlarge it, then you should enlarge it for sure. But if you have no problem at all with your vision, and the doctor just said, yeah, it would drain, I say, yeah, surgery, I'm gonna get a second opinion.
Oh, okay. All right. Now, obviously, I think say be Elizabeth Corner. Now, Busa say, oh, tearing problem. What made you go to see the doctor? So,
no, that was my response to Elizabeth.
Oh, okay, okay.
Yeah. Mm-hmm.
All right, okay. And then you got the next question. So, my grandson failed the school's eye exams, and they gave him glasses, but he didn't wear it. Is it going to get any effect for not wearing it?
Yeah, if he failed the eye exam, usually means the vision is actually pretty poor. And pretty poor just means uncorrected, he's not seeing very well. So that puts him at risk for a few things. So one, it means his ability to see the board is going to be compromised. And so that means he'll struggle to see the board. He'll struggle to pick up concepts. He may fall behind in school. And then I also don't know, sometimes the glasses are just to correct both eyes. Sometimes they have to correct for one eye that's really bad. And if that's the case, then he'll definitely have an effect, because if that eye doesn't get corrected and it doesn't receive the proper stimulus that it needs for the brain to make those connections between the eyes, and he doesn't get it in time, it can be a permanent thing. So we'll see people all the time where the eye anatomy looks normal. It looks like a normal eye, but the person can't see very well out of that eye because they never received the important stimulus they needed when they were during a certain age as a child. And so now they've reached a limit. That's the max potential for their eye. So yeah, it's annoying, but if you can try, these are the kind of things that you can do that the child will thank you for later in life.
Okay, that was it.
Thank you very much. Thank you.
Yeah, and now the next question, you said, Obisa said, how long do you have to change your eyeglasses, and how often you can change it? Yeah.
So for style, you can change it every week if you want. There's some people who have 10 lots of glasses. As far as your prescription, as you get older, your prescription shouldn't be changing as much. When you're young, 10, 20s, your prescription can change from year to year. But in your 40s and 50s, I would just say usually when you get new glasses, it just means your glasses are dirty. But yeah, there's nothing wrong with changing your prescription. Sometimes too, everyone is different. Some days you're seeing okay. Some days you feel like your eyes are a little bit dry, you're not seeing very well, and that can change the prescription they give you. So I would never be afraid to get my glasses changed.
Yeah, Dr. Edewase. And so now, but the map say in case Obi was so maybe the question became we know when time pajanisa and I know so want me send it to chat now. But before that, no map
question. Let me ask doctor one more question.
Okay. But remember, say what are we so Fifth Avenue there? And I said, doctor, I'll see you to the I don't know.
Me use the also from Pong.
Okay, and then particularly my Fifth Avenue no Emrasa. Now we are about opening Mr.
Okay.
And so me say but pay me for a long time but me
oh, the factory me and yeah, patron Fifth Avenue we are not at the Casanova Casa, na there baby.
Oh, can you dance it? When you quickly, that me Busa say, is there a certain food beer? As he eat tea, boy, and I know say is known say carrots, and yeah, boy, and na ain't gonna boy, and you any ben a bit me tea, and I said for maybe I'm gonna bring young see any crana, your man, dear. He bet me just so on, say, send your bear. Communion, sir, problem. I know say he mentioned say as we age, nobody know, of course. Ubaya dia 3 of these the ubenya bi. But diani bi wo why betimi adi anka. Obetimi abodi amaya se ne be ya betimi adi phone ya be be man ma no kora brem se ne be ya at least no more chances cross e bi asa aniwa yare omunya bi.
Okay. It means that we are Adventist nipa, nipa. So as far as a diet, honestly, so there are few. It's hard to improve on nature, and even for one condition, your friend, age-related macular degeneration. Yahoo said there's some vitamins B that occur in foods that if you take them, it can delay the progression, cut it down by about 50%. And we're so convinced that we actually have taken these vitamins, put them into pills, and given them to people. Your friend on AREDS pills. Now, you think so. Now, we don't just eat side, well, the challenge is that it's just hard for people to eat foods. I know, it's very difficult. And we also know that even though those foods help in that one condition, we don't have enough evidence set in all conditions. But I'll say in general, we know that the kind of processes that take place that hurt the eye are age-related processes, which usually are associated with oxidation or oxidative processes as well. So antioxidants, foods that are high in phytonutrients, foods that are high in antioxidants, we think but we don't have any ways of really knowing how it does it. But I would say in general, if you can get your kids to eat green vegetables, then you're a better dad than me. But those are important. Yeah.
Yo, Dr. Edwasi, opinion you.
Okay.
Doctor,
na me pese me busa with education ni our experience ni adi nyina no. One the marvel of the eye no say university. Dia afutu be na Alabama young people be on war line so a omutie say they end up say nyonyame kra na boy no. The marvel of the eye no, does it teach you something? Say it didn't come up by itself. Na bia nyame ankasa na enti you are studying no. What ended up where say would you tum say ampa onyankopon na bo ani no na say evolution there no and ama kokudrusa.
Yeah, so I think that no matter who you are, if you go to college, you have to contend with that question, which is what is the origin of the universe and how do we come to be who we are? I think one way to sidestep that question is to say, oh, it doesn't matter how we got here, it just matters why we're here. But that's a cop-out. The real truth is that it does matter how we got here. And I'm a firm believer that we were created. And that we need I can say that firmly. And I would say that for me personally, when you look at the way the human body is put together, it is hard for me to imagine that degree of complexity coming out of. And I know that a scientist they'll have arguments. There's a bias in the conversation, and no matter what you do, people will always disagree with you. But I think that if you give it a fair treatment, it's hard to imagine that all these structures came together precisely correctly to produce this organ that helps you see. We may not have time to go into the depth and the detail, but yes, my studies have led me more towards a creation perspective and away from evolutionary perspective.
Amen.
Yeah, and that's it. Amen. But the just say you know most soon na eti de work no. Yeah, that's it. And my abaso anti-constant bet me abaso abusa question no. Na fe de.
Okay, me that sit down. So, doctor, me show me question is say, my sister, na near first say, first of all, no crofopy bagana so be surgery. Na okoye no, na omuye no, what's in no a yano basa. Calling the year and back surgery. Near can't say the other one. Later na yenye. I feel okoye. Almost say ocular pressure no too high. And eventually no more no. Into a tree, finally, the ocular pressure near her no a call condemn. Until now when you a low eyesight of the one no more pretty, you know. Eventually, no both eyes no, and you know a completely blind. But the irony in it is on your pain, the pain is very excruciating. Just is he going to live the whole of her life with that pain, even though they never frown and how you're content with whatever she's got. But the pain no, is something unbearable. How can she overcome this? The secondary, but your secondary, one other question said, you didn't touch on pharyngium. Pharyngium, so yeah, one of the cases now, common with Africans. How does it come about?
Yeah, okay. So 2 questions. So one is end-stage glaucoma with vision loss and intractable pain. The second question is pterygium. So when the eyeball has high eye pressure for too long, it basically becomes exhausted and fatigued. And the term for that is tisicle. It becomes a tisicle eye. And a tisicle eye shrinks, shrivels, and is painful. So actually, sometimes people would say, well, just let the eye die, whatever. But the problem is it actually becomes really painful. And that's just because the nerves are firing in a very disorderly manner, and that's why it's hurt. So what we do, if you're in America, and you show up with a painful eye with no visual potential, we do enucleation, which means you go in and we take the eye out. And then we give you a, what they call a fake eye or a coverage or a patch. But the point is, if you're not seeing out of it, why should it remain in your head and cause you pain? So, that is an option for her. It seems a bit savage, but actually it's doing her a favor. So that's one option. And there are clinics, I've been in Ghana and worked with eye doctors who can do this procedure. So that's one potential option. The other thing is pterygium, correct. So pterygium is when the white part of the eye sort of grows onto the clear part of the eye, the cornea. It almost looks like a wing or like a wedge of white fibrous material over the cornea. And actually, we think that pterygiums are related to sun exposure. So that's why they always kind of grow in that central area, because that's the area that doesn't get covered by the eyelids as much. And we think it's from UV light and from dust. It's not an infection. That's a different thing altogether. If you have pterygium, it looks bad and it can change the way the eyeball is shaped. So it can affect the way you see, but we can remove it. You can definitely see an eye doctor, and that's a surgery that can be done, no problem. So usually it's a cornea specialist, so a subspecialist who does that kind of procedure. But it is something that is amenable to surgical intervention.
Okay, that's it. And the hospitals now, Ghana, and what types of hospitals now? So we take aside that fake eye, I save them from the pain.
Yeah, so let's see. I went 2 years ago. I'm just gonna call. I think I went to Tech. I think so. It's attached to the medical school. They had a very nice clinic we call Hawkeye. Like they have specialists in retina, in glaucoma. They have a training program. They have really well qualified eye doctors who trained abroad. Not that training abroad is what qualifies them, but they have very good eye doctors, period. And to be honest, that procedure, removing the eye, you could take someone who's in residency, hasn't finished their training yet, and they could do it. It is a straightforward procedure.
Doctor, I think say
okay, thank you.
I think thank you so much. New eye clinic be for ophthalmologist residency. I am very big one now. Yeah, I think maybe it could be that one.
Okay.
But a little bit smaller. Now,
okay.
Yeah, I think be a conference.
Okay. Okay. Or maybe. Well, no, actually, maybe Confanochi in Kumasi. You're right. They have. I just want to say one thing. There are a lot of American programs that go there that are building communications and networks with the hospitals in Ghana. CAF is one of them. I mean, they said they have a relationship with University of Utah as well. And I think Imam Gladys, Dr. Jepaku, they pioneered a lot of those connections. Having said that, sometimes you feel sad, they don't know how to do medicine. And I tell you, Seth, when I went to Ghana, I went to 2 different eye hospitals. ABI Adino, it escaped me right now. But the quality of medicine that I saw being done there, yes, it wasn't comfortable. No, the accommodations aren't nice. But the quality of medicine I saw, I would send my parents there. I would have no problem. So in case, I just want us to know, Seth, yes, it's nice when our brought folk come and help us, but we also know how to do our own things. Okay.
Yeah, Dr. Darcy. We find time no copa na Dr. Kasache. It's remember crying for just your last question. This time after this question, be a intimate to ask your question. Be I'm Salome Usu from Pong. I was a question, Doctor Usu from Pong. Salome. So that's also the with the question.
Hi, Ian. It's Salome. I just had a quick question. Well, 2 or 3. My first question is, I wear contacts long term and I never take them out until it's time to change them. Do you think there's any long-term effects with that? Because I know I have bad habits with that. And then my other question is, they did tell me I had astigmatism, and then like a year or 2 later, they said it was corrected. And I think you said that that's not possible, or it doesn't get corrected, so I want to know.
Yeah, so you probably had a mild astigmatism, right? So I have like a 0.75, some days it's a 0.5. Remember, these are all imprecise measurements, right? Depending on the day, the person who measured it, the machine that you use, there's some room for error there. What they probably mean is your astigmatism was very mild and you may not have seen much difference in the correction, meaning when they put it in your glasses, you probably didn't see much improvement. If you had a serious astigmatism, it'd be a little unusual. I'd have to kind of look at the prescription. As far as contact lenses, this goes to everyone, and I say this out of love. You can buy, so the safest contacts are dailies, period. No dispute, okay? Weekly is okay, 30 days, supposedly you can. I would never do it. I would say that, particularly for the kind of field that you're in, remember, if one eye gets messed up, that changes your ability to do a lot. If you don't have a good seeing eye, your depth perception, your ability to coordinate, all that is going to be changed. And so if you can try to do dailies for your particular profession, it's advisable. And if the question is, well, have I ever seen people who wear contacts for a long time come away with eye infections? Debia. Even last week, I saw one girl, she had a terrible corneal infection. It gave her cataract. She lived with it for 5 years, nothing she can do about it. So, I don't think you want to tempt fate.
Okay, thank you. So switch from monthlies to dailies?
Dailies or weeklies or dailies. That'd be and honestly, they're more comfortable, that'd be my advice. But everyone's risk level is different. But I'm not like scolding you, but I'm just telling you, like, a lot of the ophthalmologists will just do dailies, we don't want to risk it.
Okay, thank you. I'll do better.
All right. And then you say the addition ABC. Dr. Emre Dr. Thompson Dawase. And then Dr. Ayo on call. And you open your name, say because by emergency. I'm your friend. There's no point yadom. For the past 2 hours here, or didn't lie soon, you know, there was a adagio was saying no na odi beche and ne addition. I feel baby yani ya wo ya Ghana na infuturu egu eni so na ye pose ye ni na say up to now yanko I clinic bia say ipe bi na eko na eko check eni mai so na be ya ye nso no ye ni emenya hoden e de wase na me israel ansa na kra no ne me frɛ pastor me esofo e wo so pastor akode.
All right. Okay. Yo, on behalf of First Ghana SDA Church, Dr. Thompson, I was very Nyamisha, one my deep insight about our eyesight. Nyami Ishao. Now, when you say yes, dino, I can't crave near we. I sorry, dino, now Borga or Mono. Nyami, I don't know we are. People like you should be part of the reopening. Cow now was time about a kind. When I miss out be brave and you may, why am I be an radiation and name a Juma Oyano or more success on found quite new. Now we should out, you know, anywhere bushing. Amen.
Amen. Dr. Thompson Edawase. Your bomb pie amount. Let's change a bidding comopi. Any say opinion, Alex or Swa. Best say now by your closing song na my na numisia na pastor westa and addition so abon paye ama Dr. Thompson on the Juma Munso no amaye.
Okay.
As a obon paye na waka Dr. Thompson ni papa and ni mama. Ni mama dey every day or where no so.
Oh, I see.
Yeah, basu de bia.
You almost state bang.
Oh, Ohio.
Oh, yo. Beautiful. Okay. All right, let's pray.
Father Patricia Bompire, no, me
Yes.
fa announcement in Shemina ya Bompire. Na me come to Yakopon Boachna, and so no addition no ye beto so. Mom way program no ebino, ochna inside a crack a womb. Ochna no ye be oral health. Ye num mu yare awo do na ochna ye be things kakra bi wom. Nti yen so. Yambo ochna the same time. Yem lie so yem tia the share pastor ne bompa my
Yo ejapa da wase anymre with the Dr. Thompson afem yen for about 2 hours wanya butre ade a wodi enfie bebre what burning midnight kania bebre what infifre bebre toiling many years or the esua or the 2 hours actually say eja da wase that was in our for Mr. and Mrs. Thompson, raising such a wonderful, great son. Na ne ho on for so ma enipa bebre ani wasafo. shira ne papa ne maame ma omo kwatenten ne ahoden na afei shira Dr. Thompson so adwuma pa wafa oye mane nimdie mano ahobrase mano nyansa bebre tumi aye adwuma ne frɛ a wafrɛ no is a call na menim sɛ woni ne hwamo wo a waboa no edna duru san pempenso bɛboa no ne yere ne ne mma wonya sumdwe wɔ ne fie wonya pomuden na honhom so ahyɛ no ma na wayi na firi nsɔhwɛ ne musuo nyinaa mu ebinom anya ɔhaw adwuma mu ne abebrese bebre ma wakoa nkɔto saa nsɔhwɛ bi so da wafa ho so sɛ ɔbɛkyerɛkyerɛ nsɔre ne nipa bebre yakɔso ahyira no amen mu no ma nkɔso enyina pintin na ne colleagues a ɔmunya hu Kristo no ehu ne nyuma pa sane odi kan ka kyerɛ yɛn ɔmehu ne nyuma pa na mo nso abadwo di sɛ uyo onyame a wobɔ ade anyimre ne Yesu nyina no ma yɛn fa nkɔbɔ yɛ bra yɛn tan kɔ check up ntentem ma yɛn hwɛ yɛ niye ma yɛn value nipadua yi a wodi ama yɛ every say you created us in a wonderful way ma yɛn hwɛ yɛ nipadua so yie yɛn hwɛ yɛ didie ne bibia Yesua na yɛn mo ho ban na tumi asome yɛ akyɛ yɛbɛ free afidie so akɔyi bibia yɛ wo bia se yɛ wo fie se yɛ wo adwuma mu da bɔ yɛn ho ban na dwe hwɛ yɛ so a yɛn ho masɛm bi na de pachi a enyina ya sɔre aba behie mu abɛda wase ɛda wase wɔ hyira doctor ne na busua menim sɛ da foforo a yɛbɛsan ne na hyia no bɛyɛ nigye ne hyira wɔ Yesu din mu amen
amen amen agidifo ma enyina yɛ ho mespa nyankopɔ ma yɛ napa ɔma de panchi ɔnhwɛ nso abɛ yɛ ho emasem ade akye bɛkɔ enwuma so nyinaa no ɔnyɛ bambɔfoɔ ɔmfɛ nkɔ ne nsa amra ne ntimi sa me dua lai so ebio nyame Israel nhyɛ sombon so no ɔmfama Dr. Thompson na busua nyinaa ema yɛ nyame nka yɛ nyinaa yɛ ho ɛne mespa
yɛde teteme Yehowa hwɛ so amen
amen